Thank you so much, Krupa, and thank you to NASTAD and RAISE for inviting me to talk today. I'm really excited to discuss low barrier care as part of differentiated service delivery for people with HIV. Okay, so in today's talk, we'll start by talking about the differentiated service delivery strategy, then discuss low barrier care, why, some examples of it, the components and the evidence for it, then discuss implementation considerations and finish with future directions and a few polls for the audience. So differentiated service delivery, or DSD for HIV, is really a strategy of adapting services to the needs of patients. So higher need patients, more intensive services, lower need patients, less intensive services. There's a graphic here from HIV-MA that describes this quite simply as ratcheting up or down both the touch points with the healthcare system and interventions offered based on patient need and preference. And in the global context, DSD has primarily been a focus of research and programs to date for reducing burden on the healthcare system and using resources more widely. And in this context, the focus is typically on de-intensifying services for stable patients. Some examples of interventions like that include fast-track refills, adherence clubs, and task sharing. In the US, the context of DSD is a little different. Here, so far, the focus has really been primarily on intensifying services for people with complex needs, although there is certainly some room for de-intensifying services in the US setting as well. There's a recent report that was released by HIV-MA, that's a white paper, so it can be found online at the reference there, that talks about differentiated service delivery and street medicine as two promising strategies for helping us get closer to ending the HIV epidemic goals. So within the context of this spectrum of services, it's important to note that the intervention I'm focusing on today is just one part of this and is something that can be tailored for the local context. So low barrier care is not meant to be for everyone or the same everywhere. It's really one part of a larger system of differentiated care for the local context. In Seattle and King County, Washington, where I live and work, a system of differentiated care has evolved that is summarized on this slide. So lower support need and less intensive services primarily is represented by people with HIV, many of whom see private practice providers, are insured, don't necessarily have any needs even for case management. The Ryan White Part C funded clinics, two really excellent clinics here, including the Madison Clinic at Harborview, which is where I work. And then the low barrier clinics, the MOD clinic or moderate needs, which I'll talk more about today, and soon 4 other low barrier clinics. And a developing mobile team, even for people we have difficulty bringing in and engaging in the low barrier clinics. And as you can see in the map at the right, the goal of this evolving system is to ensure that we have broad geographic access to low barrier care. So what exactly is low barrier care and what do we mean when we say that? Well, first I do want to talk about the rationale. Low barrier care is really designed to engage people who are out of care or who aren't fully engaged in conventional HIV care. And looking at that group of people who are out of care and the research on interventions, there was a systematic review published recently that looked at 125 studies in the US published through 2020. And they grouped the studies into 3 main categories: using clinic and HIV surveillance data to identify, trace, and contact out of care people with HIV, or what I would call data to care; engagement of health workers to provide added support, so whether that's a patient navigator or more intensive case management; and multi-component interventions that combine these things and often had added counseling or reminders for patients as well. And what they concluded with the review of these 125 studies is that irrespective of the interventions, they had mixed results for re-engagement in care or ART reinitiation, and none of the studies led to an improvement in viral suppression, right? So all of this research, many years or decades of this work, and most of these things that we've studied so far haven't translated into improved viral suppression. But for the highest need patients, we really need to change the structure of care available. So how I think of low barrier care and a structural intervention is represented on this slide. For individual interventions, which do help people, the goal is largely around helping them get through the maze of the US healthcare system, of the social services system, doing everything we can to support them within the system that we have. A structural intervention like low barrier care is really instead changing the finish line to make it much easier for people with complex lives to engage in care and to get on treatment and to stay virally suppressed. And taking this approach requires us to shift from focusing on the patient factors or the client factors and really looking more closely and changing our programs to improve engagement. So the definition of low barrier care, as I'm using it here, is a care model designed to engage people with HIV who are not engaged in medical care as it is conventionally organized. In other words, our current clinical services are not effectively reaching them. And this provides primary care, including HIV care, for a defined cohort of patients. So this is not a group that elects to come sometimes. It's really a group that is enrolled in a low barrier care clinic and that we're designing our services for. I do want to briefly say before I go into examples of models that I fully recognize there are lots of creative approaches out there that aren't published in the peer-reviewed literature and that we may not know about. And I would love and invite people in the audience who know about these to talk about them today. So there are many unpublished interventions. I'm focusing on ones largely that have been published, which I realize is a subset of those. So the MAX clinic model, which stands for maximum assistance, was our first low barrier clinic here in Seattle. And that started in 2015. The criteria for patients who can be referred rather from any source is really that people are virally unsuppressed or not taking ART, and they haven't been effectively engaged in care after lower intensity outreach attempts. So that may be a clinic person calling them, a public health person calling them, and really offering and helping support services to get back into care, but that's still not working. When people are enrolled in the MAX clinic, they have walk-in access to care. They have integrated high-intensity case managers, both with social workers who do the medical case management, coordination of care, insurance, and public health, DIS or disease intervention specialists who really serve as the non-medical case managers and provide general psychosocial support, coordination with other services beyond the medical ones, and incentives. So we give people cash for getting their labs drawn once every 2 months, $25, and for viral suppression, $50 every 2 months. We have grocery vouchers that we give out up to once every other week, snacks every time people come to clinic, unrestricted bus passes, and we initially started with handing out cell phones, but ultimately stopped that because it did not work well. On the right, you can see our model. I'll talk about that a little more later, with the dark circles representing where we started and the expanding light circles, our current model. So the patient population enrolled in Max Clinic is relatively small, a focused group of high need patients. And this table summarizes the 357 patients enrolled from 2015 to April of this year. And what the demographics show is a lot of similarities to people with HIV in King County in general, with a few notable exceptions. So certainly more cisgender women. That's about 13% in the county overall compared to 21% in Max Clinic. More transgender or gender diverse persons, 4 versus 1%. And fewer non-Hispanic white persons. So 51% in the Max Clinic compared to 67% in the county overall. Where we see the biggest differences compared to the more general population of people living with HIV is in these complex comorbidities and social situations. So at the time of enrollment, almost all Max Clinic patients have either unstable housing, homelessness, substance use, mental health disorders, or some combination of all of those. A full 42% of our patients have had all three at the time they enroll. About 2/3 of patients are homeless. I would say of that 1/3 that is housed at the time of entry, many of those are people who are in supportive housing and were formerly homeless. Substance use, very common, predominantly methamphetamine, 40% injection drug use, and very common psychiatric disorders, including severe mental illness with PTSD, bipolar disorder, and psychosis. So looking at the impact on viral suppression, the first study that we did was looking at the 50 patients enrolled in Max Clinic during the first year, those first 50, and comparing them to a standard of care control, 100 matched patients who remained in Madison Clinic, and looked at their outcomes in the year before enrollment and the year after enrollment. And what you can see here was a really substantial increase, with 20% of patients in the Max Clinic having had viral suppression at least once in the year before enrollment, up to 82% in the year after. And importantly, in the control population, viral suppression also increased, again showing excellent standard of care services in Ryan White Part C clinics. But still, patients enrolled in Max Clinic were over 3 times as likely to achieve viral suppression. We also conducted qualitative research to understand patient views of the clinic and try and get a sense of patient views of what were the most essential elements. And the key theme that came up when patients were asked open-ended questions about when asked open-ended questions about their experience in the clinic and what was the most important to them, the key theme that came up was how people feel that they're treated and how their social circumstances are addressed. And as for incentives, there was heterogeneity, with some patients seeing them as being very important, others not as much. I would say bus passes are very important to patients, and cash incentives were often seen as more of a bridge, an important thing that got people in that wasn't necessarily as important over time. But as shown in the quote that's here, I won't read, for some people, that was really the crucial thing that got them to viral suppression for the first time in their lives or in a long time. Pardon me. So next, the MOD clinic evolved, or the Moderate Needs Clinic. And the MOD clinic came out of partly our finding that a lot of people were being referred to Max Clinic who were virally suppressed, but they were missing clinic appointments. They had other chronic illnesses that were not well managed, and they needed a different care model, but perhaps not quite the Max Clinic. So the MOD clinic is different because it's co-located in Madison. It's in the same physical space, but again, a defined cohort of patients who are enrolled and providers who are available for MOD clinic and seeing MOD clinic and only MOD clinic patients. All of the care is provided on a walk-in basis. That's really the key thing. And there is an additional patient navigator. The MOD outcomes shown here on the right did not have a substantial increase in viral suppression, in part because baseline viral suppression was relatively high, certainly lower than the main clinic, but higher than the low barrier clinics. But engagement in care really increased and sustained viral suppression. And in a separate controlled analysis, people who could have enrolled in MOD but didn't or weren't referred often lost viral suppression. So I think there is something about a model like this that can help avert people from stopping medications. The pop-up clinic in San Francisco is another similar low barrier model. The eligibility, this clinic was really designed for people who are homeless or unstably housed, viremic, and missing care appointments. So although pop-up may make you think of the clinic being a pop-up, it really is a brick and mortar clinic, and it's there for patients who pop up in clinic after having been out of care for quite some time. They looked at the first 112 patients enrolled, in the first year, and viral suppression increased from 0 to 66% in that group. Notably, 9% of people died in that first year, and that was primarily due to overdose. The pop-up clinic also, the research team associated with it did some interesting work with a discrete choice experiment to again understand which elements were the most important to patients. And they enrolled 65 people who were living with HIV and living homeless and asked about hypothetical clinics with a different combination of features. And the 5 options were shown on this slide. Similar to our qualitative findings with the Max Clinic, the most important thing for patients was feeling that the care team gets to know me as a person, and they were willing to trade a substantial amount of gift cards or money away for having that element. And then the drop-in aspect, really crucial as well. The pop-up clinic has been a key part of San Francisco's success with long-acting injectable ART in patients who are viremic. So as many of you may know, long-acting injectables were FDA approved rather, for people with stable viral suppression. But in many ways, where I think they can have the most public health benefit, if we can really operationalize this, is with people who are viremic. Oral meds aren't working for them. And in this group, with the first 24 patients they enrolled who had viremia, there really have been so far very substantial improvements in viral suppression over time. That is resource intensive. This requires a ton of work and FTE, but having the pop-up clinic in place is also essential for making this work. So putting this all together, what are the core elements of low barrier care? And here I'm using the term core elements as really the most essential things that can't be changed, and distinguishing that from the adaptable periphery. And I, along with Matt Goldman and Meena Ramchandani, recently published a paper describing our approach to this and perception of this from our experience. And I think there are really three key structural elements: walk-in access to care, which is crucial, that integrated high-intensity case management, ideally with medical and non-medical case managers. And for the Max Clinic, incentives are crucial, but as I just showed you with the Mod Clinic example, they may not be as crucial. They aren't used in the Mod Clinic. And then some process elements that I'll talk a bit more about on the next slide. So I think as I talk to people about low barrier care, as we as a field conceptualize this and define it, I think what often comes up is people working in a context where they say, my clinic does this, we already do this. We can see patients on a walk-in basis. How is this different? So using, again, the local example here, I want to describe how and why clinics like the Max Clinic are really substantially different from the standard of care clinics. And it's important to say that standard of care, or medical care as it's conventionally organized, for people with HIV is already a really outstanding standard of care. It is not the same as primary care in the rest of the healthcare system. But walk-in access, for example, in Madison is typically for people who have an urgent need, who come into triage as needed visits, whereas in the low barrier care model, all medical care is walk-in. We don't have appointments. The social workers in the Madison Clinic are generally available by appointment. There is some walk-in availability, but it's not to the point where somebody can walk in and easily see a case manager who's often busy with other patients. In the Max Clinic, the social workers have smaller caseloads and really have then more time and ability to provide the extensive care coordination that it takes to support patients. Incentives are only in the low barrier care clinic. The care philosophy for low barrier care, I would say, is there's an excellent standard of care in both clinics. In the low barrier clinics, because people often have very complicated lives, a lot of things going on, are in crisis, may or may not be willing to go into the hospital or emergency room, we really have to focus on the top priorities and what's realistic for patients, how many medications they can take. We are often doing off guidelines care and trying to have creative approaches when patients don't want to go or don't want to stay in the hospital. Cross-agency collaboration, again, just more intensive in low barrier care, and this model requires constant tweaking and adjustment. Okay, so let's move on now to implementation considerations for anyone who is working or is interested in thinking about implementing a low barrier clinic. What are the considerations? First, I do want to acknowledge the models I've talked about so far are in Seattle and San Francisco primarily, which does have some very specific local context factors. They're both urban settings. There's a high level of viral suppression among all people with HIV. So in King County, 87%. That's consistent with meeting the 95-95-95 goal. So we are really working on focusing our EHE services on that small remaining population. We're Medicaid expansion states, we're both EHE-funded cities, we have supportive political leaders, strong health department university connections, and some of the key barriers to care engagement among people with HIV are homelessness and unstable housing and methamphetamine use. So these models were really designed for this population. Across the US, there's of course large variation in HIV epidemiology, in barriers to care, what those may look like in a more rural setting or a setting without good transportation. variation in resources, the social and political context, and the policies and laws. But I think that the central idea of low barrier care, really adapting the healthcare system to reach the highest need people with HIV, is a universal need, and that this model is adaptable. This slide shows the low barrier clinics that we are aware of in other parts of the country, many of which are just launching and just developing, and we hope to see more data from soon. Again, I'm sure there are others that we're not aware of. And I just realized that says Desert Age Project in Philadelphia, which is not right. So sorry to any Philadelphia colleagues. I apologize for that mistake on the slide. So we recently published a paper also putting forth a framework, pardon me, for low barrier care implementation. So I want to be really clear that when we put together the Max Clinic, it was not according to a framework like this and a step-by-step considered process. It really was something we implemented, learned, changed, but looking back and working with other people over time, we've really put together what I think are some key considerations for implementation. This is shown according to the EPIS model, which separates implementation into the exploration, preparation, implementation, and sustainment phases. Today, I'm really just going to focus on those 3 points in preparation, because I think that's where many people are, and just offer a few lessons learned. So first step in preparation is identifying the clinic, site, and organizational partners. And I think for any low barrier clinic, you do need to have a clinical care partner, somebody who's delivering the clinical care, a medical organization with access to hospital resources, especially since many patients are quite complex, may be seriously ill. It is important to have the access to appropriate inpatient and emergency services. But I don't think this needs to be an infectious disease physician. I think it could be with a primary care physician who does HIV care, or perhaps with advanced practice providers. It'd be interesting to see more examples of that. Support services, all of those social support services are another key part, and having a partner with expertise in that area is key. So one way to do this is bring additional services into a clinic setting, which is what we did with Max. Another way is to bring clinic into social service setting, and that's what the new low barrier clinics in King County have done in partnership with Aurora Commons and Catholic Community Services, to well-established social services organizations. The new low barrier clinics have brought clinic into those settings. And I think the health department is another key partner. And really, ideally, low barrier clinics would be integrated with data to care activities, and gives us a way to make data to care more effective when we have an intervention to offer people we find who are out of care. So the key principle here is the clinical care and support services need to be fully integrated. That means one team, one cohesive team, and in the same place. The next step that we have in this model is developing buy-in and funding plan. This is very complex and really is highly dependent on the local context. So I've shown here the funding sources for different pieces of Max Clinic, but won't go through those in detail, since again, a lot of this depends on if you have Medicaid expansion, EHE funding, and who the partners are in something like this. The key principle in getting buy-in from the partners and developing a funding plan is making sure that you have a plan to minimize the financial outlays. So I want to be really clear, this is an expensive intervention. It is not cost saving, but thinking about how we can do this in the most financially responsible way, I think is helpful for getting buy-in. And two key points to consider are 340B funding and ADAP medication rebates. We can talk more about that in the discussion for people who are interested, but those are crucial to making models like this sustainable. The staffing model, really important. Most visits in low barrier care are not with a clinician. So it really is the case management staff, medical and non-medical, who are so crucial to this model. The non-medical case manager is a role that I think can be filled by a variety of job classes. So we use DIS, that could be a community health worker, a peer or professional navigator. The people you hire are really the most important element. Like in almost everything we do, a lot depends on who those people are, their skills, working with this population, or ability to develop those skills. And the clinician, as I mentioned. So one really important thing to think about with these models is I don't think in most cases it's realistic to start off with a fully staffed model of we now have everything staffed and now we're ready for the patients. This slide shows, I'm realizing now the font is a little too small here to read and I apologize. But in 2015, when we started the Max Clinic, we really had less than half FTE MD time and one non-medical case manager. That was really how we launched it. That was it. And then quickly had more physician time and another dedicated non-medical case manager. And as you can see, with the growth in patients over time, blue here is the number of active patients in Max Clinic at any one time. Red is the total ever enrolled. The staff expanded as needed with the clinic. So we could not possibly have started this with the fully staffed model like we have now. We had to start small and grow. So I showed you this figure before and do just want to emphasize where we started in 2015 and where we are currently. All right. The next step is defining the approach to each intervention component. And for this, I'm just going to stick with the structural elements, those three that I showed you earlier in the talk. And some key principles, I think, to think about here. Walk-in access to care is one of the most important elements and probably the most complex from an administrative standpoint, because our healthcare system in general depends on scheduled appointments and is built around that. It is really tricky to bend the administrative processes and change them to go to a walk-in model. And really importantly, walk-in does not mean immediate access to comprehensive care. People sometimes have to wait. When a lot of people come in at once, we have to triage. And sometimes for the clinicians, and I'm sure for case managers as well, you have to get comfortable working without all the information you might want. A psychiatrist who works with the pop-up clinic said he had to get comfortable treating people partially blind. We don't always have all the information we want at any one time. The high intensity case management, as I went through, I think really means a lower caseload, that's the key, and more time to be spent on care coordination and support. Incentives do not need to be cash. That is actually complicated to do and can be done. Happy to talk through that, but I think the key thing here is something that's a bonus, something that makes it worthwhile for people to come into clinic and to prioritize it that day. And as we've gotten some feedback from community partners, maybe we shouldn't even call this incentives, since a lot of what we are doing and how patients see it is helping them address the key needs and basic needs in their lives. Okay, so I want to move into future directions very briefly, and then the polls and discussion. So I think these are some of the key questions about low barrier care that I find the most interesting and important right now. How can the low barrier care approach be adapted to different settings? So how can this work? And what would it look like in states that don't have Medicaid expansion, or in rural areas where you can't set up a clinic in a key core and bring people in? Are there mobile models? Are there other ways that this needs to look? What is really core? I put forth to you our conceptualization of the core elements, but I think as we gain more experience with this model in different contexts, we will probably learn, and that will evolve as well. And then we need a better understanding of costs. So not just how much does it cost, but also what about different models like Max Clinic, the standalone, very high intensive, versus MOD, which is integrated into the main clinic and just the walk-in care, and how those relate, of course, to the patient outcomes. So in summary, and I'm just realizing I didn't finish my summary slide. So in summary, differentiated service delivery is key to address the needs of all people with HIV. We talked through the system of differentiated care, the example in King County, and how low barrier care is one part of the differentiated service delivery approach. And that this model, I think, is adaptable and can work in different contexts with different resources, different populations. So I would like everybody, these instructions will be on the next slide. I now just want to go through 4 polls with the audience before we move into the discussion. So please look at this here, and with your cell phone or computer, whatever you have, go to slido.com, enter the code shown here, which again will come up on the next slide, 2334646, and go to the polls tab at the top. And with that, you should then see this question. Again, there is a QR code and instructions for joining. For those of you who can see it, are there any low barrier HIV clinics in your area? Okay, interesting. 81%, probably some reflects local audience in Seattle and King County, but I'm sure also there are some people here who have clinics in their area that we haven't talked much about. And I really do want to invite you to please put things in the comments so that we can talk a little bit about that if you're willing in the discussion section. And it looks like about 30% of the audience either doesn't or doesn't think so. So that is helpful to know. Okay. What do you think? This one is a word cloud. So you have to choose 1 to 2 words at a time, but you can put as many in as you want. What do you think are the biggest barriers to implementing low barrier care in your area? So if you're in Seattle and King County, I guess I would invite you to think not just about our local, but what you anticipate are barriers in other settings as well. So cost is coming up, and I anticipated, and we'll see if that stays the biggest one. Geography, which I think is probably getting again at rural, urban, or difficulty accessing. Politics, money, same thing as cost. Yep, rural, provider schedules, absolutely. Qualified staff or lack of qualified staff. Stigma, bureaucracy, provider buy-in. So that's interesting. That's interesting. I assume that means not having provider buy-in. Okay, so some key things. You can all see this here. I think I would summarize cost, budget, money, resources, all are number one. And then political will and political considerations and perhaps qualified staff as well. So that's interesting. I would also really love to hear a little bit more about this in the discussion section. Great, and desire, I don't know if that means the responder or other people, but I do note that as well. Okay, back to a poll. So this is really a hypothetical question because we don't have this to offer right now, but just interesting, would be interested for, and let me ask, I probably should have said that first. Okay, so for anyone who might be thinking about implementing low barrier care or in an area, would you be interested in a learning collaborative, a peer-to-peer type learning group with people implementing low barrier care? And I'm realizing on my slide, I can't see the total number of people who are answering or have answered, so I apologize for that. And it looks like that is stabilizing with people saying yes, definitely, or maybe. So that's helpful to know. And I suspect some of the people who've answered here are doing low barrier care and may still be interested in having more interaction with other people who are working in low barrier care settings. So that is really helpful. Thank you. Okay. And the next one is really designed to lead us into the discussion. So what more do you want to know about low barrier care? Or maybe I'm realizing now I should phrase it as, what do you want to talk about? What are things that are on your mind in terms of questions or concerns that you may have? This one is a free text, whatever you want. And you can also type, of course, in the chat on the Zoom. Models. Yes, I think knowing more details about the models that are available, how they're doing things, how they might be different from each other. Strategies for rural areas and less densely populated. Yes. How to administer the walk-in aspect. Non-clinical setting applications. How peer work can become more integrated. That's a great topic. The right blend of staffing, applications specific to transgender care, how to pay for incentives. This is great. Thank you. Okay, so we've got a lot to talk about. Challenges and solutions, mobile versus fixed sites, and the best practices to integrate community health workers. So I would say that comes up with community health workers and peers. It sounds like there would be interest in discussing that and thinking about how that fits into different models. Okay. Thank you all so much for participating in that and giving us some fodder for the upcoming discussion. All right, so I just briefly want to end with my acknowledgements and thank yous. First and foremost to everybody who is and has been on the MAX team, all of our collaborating organizations, some key leaders with other low barrier clinics, and of course the funders, both for program and for research. And with that, I will stop sharing, and Emma, I think it's Emma and Krupa, turn it back to you for facilitating the discussion. Thank you so much.
Great, thank you so much, Julie, for that talk. So there's some questions in the chat that I thought we could just run through, and then with remaining time, we can maybe discuss some of those other points that people were bringing up in the poll. So I'll just read some of them out. One question is, what has been the average number of patients in the MAX clinic over time? And what is the criteria for discharge to a lower level care model, like you have people transition out of MAX?
Great questions. So the average number over time has grown a little bit each year. And right now we are at about 250 active patients, which I would say has actually been relatively stable over the past year. Unfortunately, that is because the rate at which we're admitting people is has recently been roughly balanced by a very high number of deaths, particularly due to overdose and the huge epidemic of fentanyl overdoses that we're having right now. So graduating to lower level of care is an excellent example of a way that we had to rapidly adapt and change our model based on what we were seeing. So we went into this thinking of MAX Clinic as a transitional model and the goal to get people back into a lower level of care. And that hasn't worked at all. So I think there are a few things. One is that the same reasons people come into the MAX Clinic and the many barriers they have are still in their lives. We are not changing their lives. Even when we can help them get housing, I should say we're not fundamentally altering many of the things that people are dealing with. And the chaos comes and goes cyclically. The other thing is when we engage people who really haven't been engaged and gain the trust with the system and they really develop tight relationships with the team, they are not interested in going to another place, right? This is their care group. So we do graduation, what we call it, rarely now. Sometimes it comes up, sometimes a patient wants to do it, sometimes there really is a big difference. But for the most part, this is a one-way model. Thank you for that question.
Great. So two more questions. Someone's requesting you discuss challenges you encountered with the provision of cell phones to patients. And then additionally, what kind of average wait times do walk-in patients experience?
Okay, that is a great question. So cell phones, our experience with cell phones was that people, almost everybody we gave them to either lost or had them stolen or sold them within a very short period of time. And the staff was spending a ton of time on trying to replace people's phones, getting service shut off. And the people who held on to them mostly didn't answer our calls. And they wanted to come in when they needed to come in. And really, that was the service model that worked. This might be different other places. I would say in our qualitative research, one person said, I hadn't had a cell phone before. I didn't really need it. So for us, it truly just didn't work. And we spent an inordinate amount of staff time on those lost and sold and stolen phones. And I just blanked out on the second part of the question. I'm sorry. Oh, average wait times. It varies so much. I would say that in general, the team does a really excellent job with triaging. What does this person need? What are we going to do today? And the whole team is in a hallway and figures out who's seeing who and does a lot of coordination. So I think, and I know some of you are on the call, so correct me if I'm wrong, the average wait time is relatively short to come back and start talking to someone on the team. And for the people who need to see a doctor, I'm sorry that I can't even guess at the average, but it varies a lot.
Great. Another question related to funding, so potentially also an opportunity to discuss funding more. Someone is asking, is Part A funding available for medical care for patients who do not qualify for Medicaid?
Is Part A funding available for patients who do not qualify for Medicaid? So I think that is going to be I think that is probably somewhat a context specific question. Again, anyone with more expertise than me, pipe in. For us, ADAP, so essentially Ryan White Part B, the state program, can pick up the cost of care. Lydia, I see you. Excellent. For people who do not have Medicaid. Lydia, I'll hand it over to you next, and maybe you can tell me if this is a Washington state specific thing or the extent to which you think that's true elsewhere.
It is not a Washington state specific one, but we have worked out some really interesting workarounds. Like the Part B here pays for case management across the whole state, in addition to even if you are in the TGA. And we have some interesting things on the outpatient ambulatory. So each state has worked out its own funding mix. So you are accurately stating what we do. But you'd have to go to that jurisdiction and ask that same question of, the Part A and Part B, wherever that person is. But there's nothing that would preclude it from doing it if that's the negotiation that the funders have come up with.
Thank you very much, Lydia. Appreciate that.
And there's also been some folks chiming in about wait times, so I'd point people to the chat on that. There's a request to discuss mobile models of these services.
Yeah, so that I will again tell you my thoughts and invite anyone here who has experience with mobile services for people with HIV to chime in. I would say that by and large, it is challenging to do a mobile clinic when we mean a clinic that moves around from place to place. So for instance, in healthcare for the homeless, there are mobile clinics that sort of set up shop at different places and see people coming in. For people with HIV, that's a challenging model to find the right place to park it, to get it publicized, to have people with HIV come in for HIV care. So I think that is unlikely to work well in most areas and does have a really high cost in general for the number of patients seen. However, a mobile team going to people or going to their homes when we can find them or wherever they are staying, I do think is a model with good potential. So that's more like a street medicine model. Although I would say a lot of people who need these services aren't on the street. They're actually in supportive housing or in a place where we can meet and greet them. So I know San Francisco is starting a model like this and studying it. We've just launched ours within the last month and a half or so. And so I do think we have a lot more to learn about how effective those can be and how those can work best. So I would encourage us to think of mobile services, meaning us going to patients rather than a mobile van for HIV.
Great, there's some agreement with that statement in the chat. So that was all the chat questions. Julie, do you still have the list of the topics that came up in the poll maybe in front of you? You could address a couple.
Yes, I will work on bringing that back up. I do think the two that come to my mind foremost were around peer models and the role of peers and the role of community health workers, which I think is a really great question. And I, again, I really would love for some people to pipe in who are doing this. So in the Max clinic, we do not have peers and community health workers as part of the model. In the mobile team, we do. And in the other low barrier clinics, this is different. So to me, I think this really depends mostly on your organization, the organizational partners, who you can hire. And again, ultimately, the most important is the people you are hiring for those positions. So I do think a peer navigator who understands services well and is really skilled could absolutely be an important part of a low barrier care model, similar with community health workers. I would love for some people with experience to pipe in, if you would be willing. That's okay, we can keep going. And someone can turn on their video if they want to talk, that'd be helpful. All right, sorry, I'm working on pulling that back up. I think just thinking about the biggest barriers, the cost and the funding comes up. So I do think this is, what can I say about the cost that can be helpful? I think that for us, it has really been crucial, again, that we have Medicaid expansion and to work as part of those services and to build on to the existing services. I do think as a first step in terms of cost, it is worth thinking about a model more like the MAUD model, if that's more doable for people. Again, I would point out that model didn't seem to increase viral suppression the way that Max Clinic did, but in an area with really restricted costs, I do think it may be more feasible to add in a process within the main clinic to see a cohort of patients on a walk-in basis. I think EHE funding can be used. I know EHE funding can be used because that is what we're doing, and it can be used for things like the provider time. That is one of the most difficult ones, to find provider time in a way that's not dependent on productivity. And I think advocating for continued funding for this will be important. And Matt, if you are still there, I would love to invite you to comment on the funding and the cost piece as well, and any thoughts or suggestions you may have for people.
Sure. Thanks, Julie. That was really a great presentation, super clear. I think really delineated a lot of important issues. I guess my only comment would be that the care of HIV is expensive, period. And so to me, the way to think about this is, what is the incremental costs of successfully treating a group of patients who have hard lives and who are difficult to treat? And if, are you willing to spend 20% extra for that group of people, which might be, say, $4,000 per year per person, recognizing that their meds alone probably cost $20,000? And I guess I think that if we're really going to make progress, I don't see any way around that. But I'm interested in what other people think. The low-hanging fruit has been picked in many jurisdictions.
Yeah, I agree. Thank you, Matt. Kathleen Brady. I wonder if you'd be willing, Kathleen, to come off of mute and talk a little bit about what you just put in the chat.
Okay. Hi, it's nice to see you.
Hi.
Yeah, so we are funding a low barrier HIV clinic at our syringe service program called the SANA Clinic. And so we are funding them for the actual, outpatient ambulatory care services through our HRSA EHE grant. But they already have funding for other Ryan White services that they've had for a number of years. They have medical case management. They fund, They have a food bank. They have on-site mental health and substance use disorder treatment. They have a wound care clinic. And those are some of the services that they have. So it's basically, we're cobbling together the different funding streams to really come up with the low barrier model. So the one thing that we have not done with our low barrier model, so people can come in and they have a medicine closet, so people can come and sort of essentially do, directly observe therapy, etc. They can get mail at the syringe service program. There's a lot of other services that they can get there, but we don't have incentives. And so I was the one who put that in there about how do you pay for those incentives? Because those are not things that that we could pay through our Ryan White grant.
Thank you, Kathleen, so much. First, can you say the name of the clinic again? Is it the SANA, S-A-N-A?
S-A-N-A, yep.
S-A-N-A, the SANA Clinic. Okay. And then I guess in terms of incentives, and I will talk about our cash incentives, I do think it's, again, interesting to hear about that model, and perhaps, like the MAUD clinic, does beg the question of whether incentives are essential. Cash incentives in the Max clinic really, let me back up. Cash incentives, I do think, require, without a doubt, a non-medical partner. So because of anti-kickback statutes in US federal law, A medical provider cannot pay someone to induce them to engage in services. And even though this was really designed more with, I would say, orthopedic surgeons in mind, examples like that, it also applies to us. We cannot pay people to engage in our services. But a partnering organization who is not the medical provider, like Public Health Seattle-King County, like a community-based organization, can give the incentives without running into trouble with that same anti-kickback statute. You do have to watch the amount, because if it is more than $600, that requires reporting and essentially tax reporting. So I think the key point to keep in mind from me is, doesn't have to be cash. Many, many things can be incentives. If you do want to use cash, it has to be a non-medical partner dispensing that.
Great. Thank you so much, Julie. Oh, Kathleen, did you want to respond?
No, I was just saying, so, but how do the non-medical folks providing the incentives, where do they get the funds?
Oh, sorry, how's it paid for? Yes.
Yes.
So that comes from Washington State Department of Health, our very supportive and wonderful colleagues there who do fund that with non-federal sources.
State general, we have state dollars. I don't know how different states have different, but we get a fairly significant HIV kind of chunk, and we prioritize it for things like incentives, things that can't be funded through our normal, like Ryan White Part B or CDC or some of the other funds. So we hold it back for that. And so that would be a negotiation that you would need to have with your funders.
Yeah, we get state rebate dollars, so that's 340B dollars, but it's my understanding we cannot use those for
dollars.
Incentives, and we get general funds from the city, but that amount is very, very small, and about only 5% of our operating budget. It pays mainly for staff.
Yeah, I think that's the conundrum with those are the dollars that are most malleable, for lack of a better word, and we have so few of them to apply to the innovative approaches. But those are the only ones I know of, is either pulling like city, state, local funds, is to come out of my federal funding stream and to come out of my rebate dollars is the only way I know how to do it.
Great. Fascinating discussion. I do want to wrap this up here because I think Krupa has some closing remarks she wants to say. A big thank you to Julie, and just a nod to everyone to continue the discussion. I think reaching out to Julie and others on this call is a great way to keep talking about it. Krupa, over to you.
Thanks, Emma. Thank you, Julie, for a wonderful presentation. And thank you all so much for your participation, great questions and discussion. Just wanted to remind folks or let folks know about our next webinar, which will be next month, Wednesday, June the 21st. And we will be sending out more information about that soon. And if you have any questions for any of the folks here today, please reach out to us. We will be sharing the slides and the recording of today's webinar as well with all the folks who registered. So thank you all so much. Have a great rest of your day, and we'll see you next time.
Thank you.